Welcome to Acuity Acumen, the podcast where we illuminate leadership and inspire change. I'm Deanna Armstrong, an executive coach working with leaders in the life sciences and biotech industries to help them sharpen their leadership skills and drive real change. This podcast is proudly sponsored by Armstrong Walker Coaching and Consulting, where we empower leaders to reach their full potential. As AI continues to transform industries, the need for soft skills like self-awareness, emotional intelligence, and authentic leadership has never been greater. With CEO tenures at an all-time low, leaders today face high pressure to not only reinvent their organizations, but themselves. It's not enough to manage strategy. You need to connect authentically with your teams and lead with purpose. Each week, we'll explore actionable strategies to help you navigate this high-stakes environment with confidence. Remember to subscribe on YouTube and follow Acuity Acumen on Apple Podcasts and Spotify. Now, let's dive into today's conversation. Welcome to Acuity Acumen, the podcast where we illuminate leadership and inspire change. I am your host, Deanna Armstrong. In today's episode, we are honored to host Dr. Fred Cerise, CEO of Parkland Health, one of the nation's largest safety net healthcare systems. Dr. Cerise has dedicated his career to transforming healthcare delivery and improving health equity. We will explore how Parkland bridges the gap between public health and biotech innovation in North Texas, Dr. Cerise's leadership philosophy, and the critical role Parkland plays in addressing the region's most pressing healthcare needs. Whether you're passionate about leadership, healthcare, or the intersection of both, this conversation will leave you inspired. This episode is proudly sponsored by Armstrong Walker Coaching and Consulting, empowering leaders to navigate their journey with clarity and purpose. Now let's dive into today's conversation, where we can drive impact and innovation. Welcome to the show, Dr. Cerise.
Thank you. It's good to be here.
Glad to have you here. And just as a reminder, on this podcast, what we do in the first part is we talk about leadership. And then the second part, we'll talk about the blooming biotech and life sciences sectors here in North Texas. Does that work for you?
That sounds good.
Okay, good. To kick things off, could you introduce yourself and give us an overview of your role and experience?
Sure. I'm Fred Cerise. I'm the CEO at Parkland Health. And as you know, Parkland is the safety net health system for Dallas County. In that capacity, we are responsible for the care of over 1 million people who are either uninsured or on Medicaid in Dallas County. In addition to a number of other groups that we serve, that's the primary group that we serve at Parkland.
Okay. Wow, that's a tall order. I think Dallas County is one of the largest counties in the U.S. too, so that's a huge patient population for sure.
And Texas has the highest uninsured rate in the country.
Really?
So in Dallas County, just about 1 out of 4 non-elderly adults, people that are not over 65 and on Medicare, but 1 out of 4 adults is uninsured. So it's a huge population that depends heavily on Parkland.
You said 1 in 4?
1 in 4 adults.
1 in 4 adults. Wow, that's amazing. Especially you have things like the Affordable Care Act and other types of insurance options. But I'm glad that we have a place like Parkland, because one of the things you think about is that you're attached to UT Southwestern, so you're getting some of the top minds in the world, even though you're an underinsured or underinsured adult here in Dallas County. So not too bad, I guess.
Yeah, it's one of the great things about what Dallas County does. I've seen public systems in other parts of the country. Nobody does it like Dallas County in terms of the support for the public system, in terms of facilities, operation support, and then the affiliation with UT Southwestern, where, like you said, you've got the greatest minds in medicine who are taking care of people who literally have no other options for care.
Yeah, that's fantastic. And I really want to dive into Parkland, but let's start off, though, talking about leadership. So what does leadership mean to you?
Oh, gosh, Deanna. When I think of leadership, I guess, how I lead, I think back to a quote in one of my medicine textbooks where they talked about becoming a doctor, and they were talking about the importance of having compassion and treating people well, and really going down that path. And then they stopped and sort of jerked you back and said, but compassion is no substitute for knowing what to do. So you have to know what to do. And so I think about that in terms of leadership, being able to set a vision, understanding the business and being able to set a vision for where you want to go. And then also, setting the cultural guardrails and fostering teamwork and hiring good people who know how to do the work, and then making it easier for them to get their jobs done.
That sounds like a lot.
Yeah.
You have to have that vision. You said you're hiring good people, and then I think good leaders and great leaders, once you set that vision though, you have to make sure that the people are coming along with you. So what are some of the things that you do when you're setting that vision for your team as we're going into a new year? Your fiscal year may be different because you're a government, but we're going into 2025. So how does that vision process look from your point of view, and how do you roll that out across your team?
Sure, yeah. So I don't do it myself. We have a good leadership team, and we have people that provide good structure, and so can help facilitate a process of, let's identify what those, the longer term things that we're going towards, some of the long term pressures, and then what are the things we want to try to attack this year and get accomplished this year. So we'll have a couple times a year, we'll do a planning retreat where we'll get those ideas on the table. We'll set some goals for the year to be able to track that. So it's a combination of being able to think years down the road about what's going to be important for us to be paying attention to, but also being close enough to the action to say, okay, these are the things that we want to implement this year. And then my style tends to be, because I used to practice, I don't practice anymore, but I like to be in the hospital and in the clinics and sort of see what's going on. And so I'll get a lot of ideas from just walking around and hearing from people, like what works, what doesn't work, and things that we need to pay attention to. Mostly, the mindset I think about it through is through what's the patient's experiencing, and how can we be operating in a way that makes it easier for patients to get the care they need and to deliver great, high-quality care.
It's that listening, right? And keeping the patient at the center of everything you do.
You hear so much, Jack, just walking around, whether it's from patients, a lot of the staff, they'll tell you what the issues are. As leaders, if we can help solve those issues, then I think, we're doing our jobs.
And so one of the things you talked about is putting the right people in place. So what qualities and characteristics do you look for when you're looking to source leaders to join your organization? Just because I know a lot of people out there, they aspire to be a CEO, a president, or, at a higher level. So what are some of the qualities you look for from a healthcare perspective?
First and foremost is kind of knowing the business. Now, listen, everybody, when they come in, everybody doesn't know the depth of the business, but paying attention to that piece, I think, is so important. I have sometimes clinical people will come to me, whether it's doctors or nurses or lab person, pharmacy, and want to talk about leadership. And I think that clinical background is so helpful because they know that part of the business. It's not required, not necessary, but it's helpful. So whether you're clinical or on the business end, or the IT end, or whatever, kind of knowing your craft first and foremost is just so important. Now, that's not enough though, because we've got certain behavioral expectations, cultural expectations, right? And every business has a different sort of expectations on that kind of behavior. At Parkland, we're the public hospital. The work can be challenging. It can be tough. It's the problems are complex, and so you got to have patience. You got to be able to work with people multiple times. Teamwork is a huge thing that I look for. The ability to kind of work and collaborate, those types of things.
Okay. Wow. So teamwork, you said you have to know your craft, right? And then also you have to And one of the things a lot of people talk about is really being able to build trust. Do you is that also an important thing that you look for in
Yeah,
people?
it's a huge thing, particularly in today's world where if you look at institutions, the society at large, you've seen a loss of trust in big institutions over the years, and so healthcare is not immune from that. It used to be that was immune, but people still trust their doctor, they still trust their nurse. The institutions less so, and so it's important to be able to be effective, to have effective teams that people trust each other and can count on each other. And then from an institution perspective, for us to be effective for our patients, for the community, we've got to be able to instill trust in the community. And a lot of that is, means showing up, being consistent, listening, providing good service consistently, being reliable, those types of things. And so those are the kind of things you look for in your staff too.
And I think that reliability piece, that accountability, I feel like that's come more in the forefront in the recent years, right? Because I hear more healthcare professionals talking about patient satisfaction, customer satisfaction, or value-based care, and those things that are coming out that are saying, hey, we're considering the customer experience too when they come to see that person. So I think that also creates a different set of skill set that you need in interacting with patients as well as other workers, employees at the institution too. But I was thinking about you have come to the point where you're a CEO and president. So when you said, I want to be a doctor, did you envision yourself in administration?
I didn't know what this was, Deanna, I'll tell you. I went into medical school to be a doctor, to do clinical work. And, when I finished my training, I wasn't quite sure what I was going to do. So I went to work with a friend of mine who had just started a residency program at a satellite program for LSU in Baton Rouge. And thought I would land there for a couple of years while I figured out what would come next. And ended up staying there for about 13 years at this little hospital in Baton Rouge. And it was small enough where you could take on administrative roles because it didn't have a real deep bench on the administrative side. It was a 150-bed hospital. And so I became the medical director after not too many years, and then became the administrator, the CEO of the hospital. And so sort of kind of gradually got into the administrative side of stuff, learning from the people that were in those roles. And then at some point I went back to school and got a master's degree in public health that concentrated on what we called clinical effectiveness or quality and those types of things in the hospital and clinic setting. But I didn't go into medical school with the idea of being a hospital administrator.
Right.
But I tell you, as I practiced, I would see things that, from the system perspective, that we should be doing better, that we can improve upon. And so I just gradually migrated from kind of the one-on-one patient experience to what things can we do better at the system level to make the experience better for hundreds, thousands of people.
Right. See, I thought you were going to say, "Oh, I was chief resident, and then I was chief this," and it turns out.
No, I was teaching medicine, running clinics, and saying, why are we doing this way? Why can't we do this better? So finally they said, okay, well, you be in charge. Right,
you become a part of the solution, right? Absolutely, and I think that's fantastic. So you talked about, you started off in a small hospital, and then you ended up ascending to a leadership president, you said, or head of that hospital,
right?
As well. So at that point, I'm just thinking about your career progression. What was next? Because I know you also worked in public health too.
Correct. Yeah. So I was at this state hospital in Baton Rouge, and when Governor Blanco became governor in the early 2000s, I just sent in my application to be the Secretary of Health for the state. Very naively, didn't know how this process worked, but I knew the business and the challenges that we were facing with uninsured people, with people on Medicaid. So decided I would try to be part of the solution. Now, I had done some legislative work with LSU, not a lot, but enough to know my way around the Capitol a little bit and sort of understand how the process worked. So I applied, and it turns out she wanted a physician in that role, and ended up selecting me for that position. So those 4 years, 3.5 years, I learned so much about public health, because we had Medicaid, we also had the Office of Public Health, Office of Aging and Disabilities, so there was all of the aspects of substance abuse office, all the aspects of public health there, and they had some great career people who were wonderful and patient teachers.
But they weren't from the medical background.
That's correct.
And so why do you think they chose you? You said you naively did it. You kind of didn't know a lot, so you had to sell them on something.
Well, they were, it was a time of, it seemed like we're always in health reform, but this was before Obamacare. State was full of, a lot of people were uninsured, and there was this desire to, transform healthcare. We're going to make healthcare right for Louisiana. So I think they wanted a physician, and so why me? Who knows? But I guess I had established a comfort level with enough people in Baton Rouge in the years that I had worked there that some people knew me, and but I think mainly the governor was looking for someone who kind of knew the business firsthand. She was a wonderful person to work for, by the way. And whenever you would propose something, she would talk about, well, what's the impact on the patient? What's the impact on the patient? It was always about the patient and the person. And I learned so much just from her approach. But I think that's what she was looking for in somebody in this role.
That commonality, because you were talking about patients also. And I think when you keep the patients at the center, hopefully you end up doing the right thing at least 99% of the time. Right,
yeah. And I had by that time a little bit of a health policy background too, and I think, the ability to kind of work with that office of the career people in the office.
Okay. So you had your stint there in government, which is really a career shift, right? Because that's not the natural progression of a physician. So you stepped out and you went into a different industry, a different sector, and then what?
Well, so the Governor Blanco only had one term. Katrina hit early in our term, and so all of our work was just sidetracked. For the next 4 years, it was all Katrina recovery. And so when she decided not to run again, I went back to LSU. In Louisiana, LSU at that time ran the public hospitals. So in Dallas, the county runs the hospital, the state runs the medical school. In Louisiana, it was the same entity.
Okay.
The medical school had responsibility for 10 public hospitals. And so I went back to work with LSU, this time in a role overseeing the 10 public hospitals. So kind of a system level role there over the public health system, which was another great learning experience, and really it was just one of those roles where I had a great team, had a great boss at LSU, and so it was a really enjoyable time until later on in the administration, the state started unloading the public hospitals. They wanted to get out of the public hospital business and started spinning those off, privatizing the hospitals, which was my signal to do something different.
So what did you do differently with that transition, with that change?
So I was in charge of the public hospitals. The governor decided that they were going to do something different there. It's not what my job was. So ultimately, I was fired from that position because my team, the entire leadership at LSU at the time, really felt a particular way about managing the need there. Because the state was going a different way, they were getting rid of our division. And so I went back to teach at the medical school, was teaching in the School of Public Health, doing administrative duties with the medical school in New Orleans. didn't think I would do anything different because my family was all in Baton Rouge. But when the Parkland position came open, I took a look at that, and it was just too good of an opportunity not to pursue.
Mm-hmm. So, how did you prepare to take on this role when you secured the CEO and president position at Parkland?
Oh gosh, how did I prepare for this role? Hopefully, by this point, I've had enough experience to kind of to understand what I was stepping into. Like, I don't think I would have pursued any public hospital role. There are public hospitals very different across the country, but the Parkland situation was, again, the level of community support for this. I left a system where we were just fighting to survive, to exist as a system, and in Dallas, people are proud of Parkland. Parkland is supported. People appreciate the need and the work that happens there. And so it was, and nationally, Parkland's got a wonderful reputation.
Yes, it does.
That certainly precedes me. And so I knew that this was a place that would be a great place to work. And so in terms of kind of preparing for that, I think understanding what you're walking into is important. At the time, Parkland was under a corporate integrity agreement. I don't know if you remember this. People that have been in Dallas for a long time will remember this. There was it was a dark time. They were kind of in the paper a lot over medical errors and quality issues,
yes.
And so they got put under regulatory control, which was a 5-year period of supervision. So that's what I walked into. Was not the funnest setting to walk into. On the other hand, you didn't have to convince people that we had to do things a certain way because you had the federal government saying thou shalt do things a certain way. So it was not the easiest situation to walk into given that setting. But you had a committed group of people that when faced with a challenge, that place responds like no other. And so you had a lot of mission-driven people who were determined to get through this for the good of the patients. And it was really an inspiring sort of 5 years to work with that team during that time.
Yeah, and I know when I asked you, how would you describe Parkland in one word? And I believe you said mission.
Mission. I think that's what I said.
You
Mission
said
or
mission.
pride. Yeah.
Yes.
But the people there really live. They buy the mission. People want to be at Parkland because they see the need and feel good about being there to take care of people who depend on Parkland.
And that's fantastic that you continued that tradition and you made it through that 5 years and plus many more, almost 10 years later.
That's right. That's right. I've been there now a little bit over 10 years.
Yeah, right. So when you think about your career over the last 10 years and what you've accomplished at Parkland, what's one or even two things that you're most proud of that you've done in your tenure?
It's hard to say. I probably one, which is quite boring, but I would say stability. We were in a very rocky period there for 5 years. To be able to come out of that. I was looking through some files today, in fact, for something, and I saw some old financial projections where our cash was just going down, 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 down. Those were the early years there, and I'm proud that now we're in a better cash position. We've made the move from the old campus, the old hospital that was 60 years old, into the new campus.
That's right.
That was
It's
under
beautiful.
construction when I came, but
Yes.
we've completed that move. Had to complete 2 clinic buildings in the process. So a lot of, I would say stability has been a big part of that, being able to meet the need today and think about what happens into the future. And then access is our big challenge all the time. And so being able to point to things that we've been able to do to increase access, to get more people into clinic, get more people into care, do more outreach. Those are big things. And we all experienced COVID and and that was another rocky time for us. But it's another one of those periods where the staff really stood up and responded, and was there for the community.
And when you think about COVID, you mentioned that you were a part of the Louisiana healthcare system when Katrina happened.
Mm-hmm.
How did going through a similar catastrophic event like that, how did that prepare you when COVID hit?
Yeah, that's a great question. I think about that sometimes. I did early during COVID because I recall as secretary, one of the responsibilities we had during Katrina or any hurricane, was managing special needs shelters around the state. So when a hurricane comes, you'll have mass shelters for people, gymnasiums and things like that. But for people with health needs, they've got wound care, or they're on oxygen, or they're on dialysis. You got to have special needs shelters, and so we would stand up these special needs shelters in different areas of the state. So that was our big responsibility, during Katrina as well. And I remember going down to New Orleans in the aftermath, and in fact, the day after Katrina, the city hadn't flooded. The levees broke, the day later. They didn't break immediately. So, we drove into the city after the hurricane blew through. The streets were dry, but then the water comes up, and all of the stuff that people saw and experienced occurred. And one of the things that I never would have, prioritized or thought about, it was just seeing the response to the state with that, and it was, you throw everything you have at that problem. I remember specifically thinking, at one point they were calling for, how many ambulances do we need to send to pick up folks, or how do we have under contracted? We're talking hundreds, and I'm thinking, boy, that's going to be very expensive. Because I was brand new, I'm thinking of running a business,
Right.
And you realize real quickly, you throw everything you have, a catastrophe of that magnitude, there's going to be a federal response. And so, and that's exactly what we saw. After Katrina, there was a lot of support that came in. And so, when COVID hit, I just remember, we throw everything we have at this, save your receipts, we'll work that part out later, but in the midst of the crisis is not the time to be,
worrying about how much is this going to cost us.
That kind of stuff, exactly.
Right, going back to keeping the patient first.
Yeah, and so, you saw that
people.
in our response where, we had 2 testing sites that turned into vaccine sites later that were doing, at that point, over half the testing in the county. And the other thing that I learned, or was reinforced during Katrina, is during crisis, we talk about equity, health equity, and disparities. Those disparities get exacerbated. And so I remember being at the Superdome, and these trucks were coming in with people they're picking up off their rooftops, and there were these big 2.5-ton military trucks. And this lady was getting off the one of the trucks, and she was apologizing. She's like, she's like, I'm sorry, I don't have a car. By the time they said to evacuate, the buses had stopped running. My neighbors were gone, so I didn't have anything else to do.
A way to get out. Yeah.
But it just hits you right between the eyes. The people that don't have resources are going to get hit hardest. And so, when COVID hit, we were very intentional about where's the need going to be greatest, and so how can we target our services to those areas that are going to have the toughest challenges.
Yeah, and you executed that, and you went out to the people.
Yeah, that was the core of our plan.
Yes, and that was noticeable, and I'm sure the community greatly appreciated you all for that too. So you're bringing up the health equity, social determinants of health, and those type of things, and I do believe that you all play a critical role in that space. And I think about the new ARPA-H grant that was awarded to the Dallas-Fort Worth area with the customer experience. And a part of that customer experience or patient experience is social determinants of health, health equity, and those types of things. So switching to the biotech industry and the blooming sector that's here in Texas, how do you see your role as the CEO of Parkland and the resources that you have being a part of this whole blooming system that we have going on here.
One of the things in this health policy sphere that people always try to get to is, how can you manage cost, quality, and access, and it seems if you sort of enhance one, you lose in another area. Parkland's setup by nature is, because we're a kind of almost a capitated system in the sense of 2/3 of our dollars are public funds, either state, county, or local county tax dollars or state Medicaid supplemental dollars, that really are directed to support the care of a population, as opposed to kind of having to rely on a series of insurance companies and whatever their reimbursement rules are, generally having to do face-to-face encounters to be able to get paid for an encounter. We're reimbursed a bit differently. It's kind of liberating in a weird way that we've got more payment flexibility, and we've got responsibility for the entire population, from primary care in our primary care clinics to our specialty care clinics to our inpatient hospital, and then to our post-acute nursing and community outreach activities. And so having that entire continuum and payment flexibility allows us to approach care a bit differently. And so we'll do things like, if it makes more sense to take care of somebody from home as opposed to in the hospital, it doesn't.
So you're doing the hospital, and you're doing the hospital at home already. Okay.
We were doing video visits before before we had the reimbursement mechanisms worked out on the commercial side, because when only 15% of your business is that commercial business, you can target the other 85% and not have to have that driven by what the commercial payers are saying to do. So it's an environment where you can sort of break the traditional rules of fee-for-service healthcare, and so with that, you're able to and you're responsible for the continuum of the population, their health, whether they're in the hospital or whether they're in the community.
Care.
And so that allows you to sort of look at things like what kind of technology or system level interventions make sense to do that. So, over the years we've done things like, our home IV antibiotic program, where we've taught people to deliver their own IV antibiotics at home. We've done email.
With a needle?
We leave an IV in them.
Okay.
So they just have to plug in.
Okay.
But they, we learned, and this is our, we have some wonderful doctors who put this program together, but they can teach people to do this. They do it better than home health nurses. We have fewer complications than having somebody come into the house, because now they own it. It's them. So they're going to make sure they clean that hub. They're going to make sure they connect it the right way. They're going to, so patients can do a whole lot more than we give them credit for. But things like that normally you wouldn't do, because that's not how you get reimbursed. Although patients like it better, and it's cheaper, because you're not paying a nurse, or you're not paying them to go to an infusion center.
And you don't have to worry about those social determinants of health. Like
they don't have to travel, miss work, childcare.
Yes.
All of those things. We'll do email consultation. So instead of sending the person to the specialist, we can consult. We share the same electronic health record. The primary care can consult the specialist. They can pull up images, x-rays, pictures, lab results, and give the primary care doctor the advice that they need to take care of the patient. We do a lot of predictive, like targeted healthcare, looking at the population and seeing who's more predisposed to a particular condition, and then targeting care, as opposed to trying to target the entire population. How can we target that subset that's at high risk for diabetes, or that subset that's at high risk for cancer that needs to be screened, without doing outreach to the entire population? And so a lot of technology that goes into identifying how you precisely target care.
And that's interesting. So how do you encourage innovation from your staff? Like you mentioned, there were doctors a group of doctors came up with the idea, let's do
patient self-infusion
Right.
of antibiotics. That's very specific. Was that the infectious disease team? I don't know. Or was it the hospitalist? Like, who came up with that? But how are you encouraging more innovative ideas like that? And then with innovation, though, there also has to be a tolerance of failure.
That's a great point. Part of it is, identifying how to kill bad ideas early, and say, yes, not everything's going to work, right? But we had, so the IV antibiotic team, that was Dr. Bavan, who is an infectious disease doctor, who would get consulted on these patients in the hospital, uninsured person who can't go get an infusion at an infusion center because they don't have insurance, and so they would stay in the hospital for 30 days and get the IV antibiotics. And so she figured, well, I bet they could do it themselves. Piloted it, showed that it worked, expanded it, and now we've done it to thousands of people. And so part of it is just having giving people the ability to ask questions and pursue, but also we do have to be somewhat intentional about it. So now, we've developed a couple of core groups and protect some time, give them some time to think about this.
You're giving your people thinking time?
Well,
as an executive coach, I tell people you need to give yourself thinking time because you
Right.
just go,
Right.
and that creativity and innovation. I love that.
Yeah, it's a hard thing for systems to do,
Okay.
because there's not an immediate ROI on that thinking time. You know what I mean?
Yes. Look at you, always with the numbers, Fred.
Right?
Always with the numbers.
So you have to be willing to say, all right, you spend some time thinking and pursuing some other ideas. And so, if you get a group that is focused on that, that tends to spread, and then they can support other things. And so, we've got a few groups that really do a lot of kind of clever thinking, and being able to give them some space and support to do that is important. And it just creates a culture and atmosphere where people. There's so many people in a system that can identify things that we could do better and want to, and so there's innovation I don't even know about. Because people are just doing it in their unit. And so one of the things that we want to do is kind of align administration, whether that's senior level or that's the administration of a clinic unit, align that with the clinical people that can work towards making the system better for the patients.
I like that. Oh, where's the patient voice? You said you have these groups. So is the patient voice a part of those groups? Because what I found in working with R&D is that we ask the patients for their insights after it's baked. And they don't like that. Like we're designing these clinical trials. We have all this great stuff, and they're like, we consulted the patients, but did we really though? Did we have them in the decision making and creation process from the very beginning, so that we can get a better understanding of their needs and their wants and the challenges that may come along with the trial design itself?
Yeah, that's a hard thing for us, right? Because we think we know the answers, and you just want to jump to the solutions. I'll tell you that our innovation center, our group that does a lot of this work, one of their projects that I love is they were looking at vaccination rates in a section of town that had very low vaccination rates, a Hispanic community. They worked with the local high school. The students helped design the intervention. They went on Spanish-speaking radio to promote a flu drive, a vaccine drive. And so the students owned it, developed the messaging, and we brought the team out there on a weekend and had one of the biggest vaccinations that Dallas County has, the health department has seen, using the community as their drivers,
The patient, yes. And it makes a difference because they see things through a different lens too. So I love that example. I really wanted to talk about, we're in this machine learning age. You hear a lot about generative AI. What role do you see tools like generative AI playing in your role in two ways, from an administration piece and then from a healthcare provider piece?
Yeah, the more you see of AI, you have to be convinced it's going to be a game changer in healthcare. It's just really the things that it can do already, and that it will be able to do. So, on the clinical side, we've I didn't even realize we were using it as early as we were. we're using it to triage radiology images. So if you come in to Parkland, you get a head CAT scan, a CT, and it shows that you may have a stroke. Well, that image is getting read by AI immediately, and it's getting flagged. So we're not making treatment decisions on that yet. We're triaging. So it gets flagged, gets bumped to the top of the stack for the radiologist to read, and it activates the stroke team, which is, you need rapid response for that.
TPA.
So as opposed to, having that scan done and then waiting for it to get read and then sort of activating, it's happening immediately now. And so several different conditions, we're using it in that way now. We've been doing a lot of predictive analytics for a number of years now. So if you come in, if you're in the hospital, we've got systems that are extracting data from your chart continuously. And so if it detects enough information to say you're at risk for having sepsis, which is a bad thing, infectious condition to have, and it requires speed in terms of antibiotic response. Well, in the old days, a year ago,
the old days.
You would, you might get some labs done. When the doctor checks those labs later, comes back, makes rounds, puts the pieces together, says, this person's at risk for sepsis. Now, in real time, all that data is feeding into an algorithm that once it triggers a threshold, it says this person, it'll trigger and say this person's at risk for sepsis, gets an alert to our rapid response team that will go activate immediately and see them. So it cuts hours out of response time and gets people their antibiotics quicker. So these are things that are kind of running in the background and alerting to point to where the problem is immediately. So there's a lot of models like that are being developed. We've been running some of those. We've got another one, a trauma mortality score, which predicts mortality for trauma patients. It helps the surgeons know when to take the patient back to the OR to address things. So a number of these predictive models that are running today, imaging. We will be piloting our ambient listening program early next year, and that is, like a patient interview like this, instead of the doctor kind of talking to you and being over here doing this, we can have the conversation, and then AI will not transcribe it, will translate that into a clinic note, and when the doctor leaves the room, can read the note and sign the note. So it helps being able to interact better and also saves time in note writing. In places that have done that, the physicians have overwhelmingly been satisfied with it.
And back to that customer
Patients
experience,
too.
that patient experience, because we were excited about electronic health records, but then you got like you said, you got the practitioners back because they were too busy putting in their data so they didn't get in trouble because they weren't capturing all their notes and everything. So it's nice to see that coming, the pendulum swinging a little bit and getting that that eye-to-eye contact, that engagement between provider and patient. So I think that's really cool. But one of the things that I always worry about with generative AI is that it's based on historical data. And there are populations that have been left out of data historically. So you're taking this in a predictive analytics point of view, but if I wasn't included in that data, is it really predicting something for me as a Black woman correctly, or an indigenous person? So I guess my question for you is, how are you correcting for that? Or I always want to make sure that when people are talking about this, especially in healthcare, that they keep in mind that it's biased information.
Such a great, it's hugely insightful. It's a great question. The models are only as good as the population that they're trained on. And so, if the predictive model is training on, elderly white population in the Northeast, well, that's how it's going to perform, and it's going to predict a lot differently on a Black or Hispanic patient at Parkland. And so, if you're using these models, you've got to train them on your own material, on your own patient population, and then you've got to update them. You've got to check to see if they're continuing to perform the way you expect them to perform. And one of the things about Parkland, because we are, we've got a strong data analytics team, we've got a strong IT team, a strong informatics team. We are being included in some of these nationwide partnerships where we share data so that some of these bigger models are getting the experience of the patients that we see at Parkland. So it's a great question, and it's an area where Parkland takes on even more relevance in a national perspective, because one, we've got the capability, and two, we've got the patient population that a lot of the academic medical centers don't typically see.
Yeah, I just think that's critical. Even if you did just historically or in clinical trials, guess what? Women weren't included in a lot of
underrepresented, right?
Right, underrepresented, and that's why you have the big push for the diversity in clinical trials, or even people in rural areas, or because they couldn't get to the ivory tower to go and do the trial protocol, from here to there. So I'm glad to hear that you're getting engaged more in that, because I do know you have a very diverse patient population, for sure, from age to rural to you name it. Well,
it's one of our strengths.
Yes. Yeah. Yes, good. So going back to Fred Cerise, who started medical school, ended up getting into administration, even worked in government, in public health, what advice would you give to, 30-year-old Fred Cerise, or even a 30-year-old or a 20-year-old who's considering a life as a physician or a life in public health?
There's so much there. I would say, pursue, if you want to be in public health, pursue your degree, do your education, and if it's medicine, you've got to go through that piece, and focus on building your skill set. You know what I mean? So if you're in public health, there's a curriculum for that. Do that curriculum, get in, and then when you start working, be really good at what you're doing. Learn what you're doing. I'm doing something very different today than I did, back in the 90s when I was starting to do this stuff. Didn't even know that this was in my future. But if you show up every day and you are performing well, learning, then the opportunities will just come. The choices will be there. But the ones that concern me are the people that are always looking for the next thing and looking for the next thing. Be really good at the thing that you're doing today, and then those opportunities will unfold. Okay.
Be good at what you, and you said that's what you look for in your leadership team too. People that know their craft, and then are able to translate it. I feel like there's something subliminal though in your career, and it's the networking that you've been doing. And it may come naturally to you, but I feel like because you've gone to so many different, what do you call them? Can't think of the word for it, but you've done so many very different things, kind of common, but you had to network in there. What role did your networking or play in your success?
Yeah, I'm not the best one on that. I'll be honest. I think I've got a lot of connected to a lot of different groups because I'm old.
You're not that old.
And I've been in some situations like that I've, as bad as they've been blessings as well. So going through Katrina, as terrible as that was, we got a lot of help from around the country, and so I met a lot of people that were interested in coming in and helping, and those connections stayed with me, and so I've been able to do some things and have some opportunities based on those experiences. And so again, I think leaning into the work that you're doing. So when Katrina hit, we went into we just dove in for the next 3 years. That's what we were doing, and you met a lot of people, and those people stay with you over the course of your career. I've got some dear friends now that I never would have run across had it not been for that experience. And so again, it kind of goes to I never did intentionally network, I know that's probably not the great message as you grow in your career. But I think, showing up, raising your hand at work. I did some stuff in the community, volunteered. And so I stayed busy. And just by default, then you connected to people.
Right. You were out there.
Yeah.
Networking.
Right.
But working.
I didn't know I was networking.
Yes, you were networking. And back to the blooming biotech industry in Texas.
Mm-hmm.
When you look back in 10 more years, what would you like for, you'll say, what was my role in all of this? What would you like for that to be, people to say about Fred Cerise?
Yeah. I mean, I think if Parkland can continue to be a leader in population health, how do you take care of a population? How do you keep people well when they're sick in the hospital? How do you get them well and back into the community? And the role of technology is going to be huge there, and the role of just health systems, health policy on delivery system design. How can we structure care to make it more convenient, to make it higher quality? How can we, using things like AI, find populations that have fallen through the cracks? We'll find you can retrieve data now for things like people who have had an X-ray a year ago, and there was some incidental finding that needed follow-up, but they never got follow-up. You can find that now.
You'll get a flag, an alert.
Yeah, so we have teams working on that kind of stuff now. How you can find people in the community that need to be screened for breast cancer that have not been screened, that are at risk. So using the data that we have, how do we target those people most in need to deliver better care? So delivery system design, population health, advanced analytics to better target and improve diagnostic ability, those kinds of things. I think I see Parkland continuing to lead.
Great. Well, awesome. Well, thank you. And I appreciate you coming today. Always give people one more chance. Is there anything else that you wanted to share with our audience that we didn't cover today?
I think we covered a lot of ground.
We did. We
Thank
did.
you.
Well, thank you so much for joining us today, Fred. I appreciate you so very much. I really do. And thank you all for joining us today on the Acuity Plus Acumen podcast. Today, Dr. Fred Cerise offered invaluable insights into the critical role of safety net. I cannot say net. Let's go back. Yes, thank you so much for joining us today, Dr. Cerise. I really appreciate you and the great work that you're doing at Parkland. And thank you all for tuning in to Acuity Plus Acumen. As you heard, Dr. Fred Cerise offered invaluable insights into the critical role of safety net healthcare systems like Parkland Health play in transforming lives and advancing innovation in North Texas and beyond. That's things like addressing health disparities, to building bridges between biotech and public health, and even policy-driven healthcare. If this conversation resonated with you, please like, share, and subscribe to Acuity Plus Acumen on your favorite podcast platforms. A special thanks to Armstrong Walker Coaching and Consulting, where leadership meets purpose, for sponsoring this episode. I'm Deanna Armstrong, and until next time, let's continue to illuminate leadership and inspire change. See you next Wednesday.
Thanks for joining us on Acuity Plus Acumen. I hope you found today's episode filled with insights that inspire change and drive your leadership forward. In a rapidly evolving industry, your role as a leader is crucial. If you enjoyed this episode, remember to subscribe to our YouTube channel and follow us on Apple Podcasts and Spotify to catch our upcoming discussions. This podcast is proudly sponsored by Armstrong Walker Coaching and Consulting. Are you ready to elevate your impact? Reach out for personalized coaching or to explore Acuity Plus Acumen Leadership Institute. Together, we can illuminate leadership and inspire change. Keep leading boldly and making an impact. Until next time.